Okay, good morning, everyone. Welcome to the second day of the ICD-10 Coordination and Maintenance Committee meeting. For today's presentations, we'll be going through the remainder of the diagnoses proposals. We have approximately 8 proposals plus addenda today. A few brief announcements. For proposals that were presented yesterday and are being presented today, we encourage you to get your comments into us by November 13. Preferably via email, as regular mail sometimes is delayed in getting to us, and we've actually received some mail coming into us well after the comment date. So email, but if you feel more comfortable also putting hard copy in the mail, we would appreciate that as well. New proposals for the March 2016 meeting is January 15. I know that it's tough to get them in by January 15th since many people are coming back off holidays, etc., or using up your annual leave before the end of the calendar year, but we do encourage you to get those things in on a timely basis. Otherwise, they will be moved to the September meeting for consideration. And given the volume that we're receiving, it would be very helpful for you to get them in even sooner than the January 15 date, if that's at all possible. ICD-10 file updates, as Pat mentioned during her presentation yesterday, the FY 2016 files are posted on the CMS and NCHS websites respectively. Also in August, we posted, NCHS with shared posting with CMS, we posted an updated expanded list of present on admission exempt codes. It basically takes what is in the guidelines, and as you know, in the guidelines we just show the range of codes that are relevant. The detail list actually breaks out the codes at an individual line level. So those new files were posted in August. I know AHIMA and others also sent out alerts to their membership about that new posting. The other thing is, and I mentioned this yesterday afternoon, but for those of you who were not present yesterday afternoon, CDC does have an additional web page for ICD-10 CM resources and information, and it basically is focusing on public health users of I-10 coded data. As many of you know, there are many that use coded data, but they are not the people who are actually reporting out the data or the HIM professionals that are using source documents to code that information. Though they are not HIPAA-covered entities for the most part, they are impacted because they are taking the coded data and using it for multiple purposes, including surveillance and other activities. So we have a web page and several resources and links to other pages, including AHA, CMS, AHIMA, and others, which are really focusing on the needs of the public health community. We invite you to take a look at those pages. If you have questions or comments, by all means, send it to us. There is a separate inbox for receipt of comments for those web pages. They all still end up coming to us anyway, but at least we have 2 pathways to get us the information coming in so that we can provide a response. And as Pat mentioned, we're looking to post new files, the addenda for 10CM and PCS by June of next year. However, we do take note of the fact that we've had requests recently and from AHA and AHIMA as well to actually try to make those addenda files available earlier than the typical June release date that we've had established for the ICD-9 CM file. So we'll be taking that under consideration, and we'll be following up with you shortly via email or the listservs on how we may be able to address some of the questions that have come up. So as I said, we now have 8 proposals for this morning and addenda, and what I'd like to do now is turn the podium over to Dr. David Berglund, our medical officer, who will present our first topic of the morning. David?
Okay. And our first topic this morning will be pulmonary hypertension. And this is on page 62 in the handouts that you have, the topic packet for diagnoses. So those following along, you can turn to page 62. And we have Dr. David Platt who will be presenting this for us. And he is with Bayer Healthcare Pharmaceuticals. And I will invite Dr. Platt to come on up. We talked a little about pulmonary hypertension. We mentioned it yesterday, alluding to it when we talked about the causes of right heart failure. And so now we are going to hear more about that. And Dr. Platt, I'll turn it over to you. And you can tell us more about yourself and the things you do also.
All right, great. Thank you, Dr. Berglund. So I'd like to thank the committee for inviting me to participate in today's discussion. My name is David Platt. I'm a pulmonary and critical care physician. I currently serve as Director of U.S. Medical Affairs in the Cardiopulmonary Group at Bayer Healthcare. And my goal for today is to present the clinical rationale for a proposed revision to the ICD-10 CM codes for pulmonary hypertension, which is a very complex and can be a devastating disease for patients who have it. And this is a very active area of medical research because of the high level of unmet need that these patients face. So over the next few minutes, I'm going to summarize our request. I'm going to present a brief overview of the disease itself. I'm going to show you some of the coding issues that we've identified, and I believe we're going to walk through the actual request. So the current diagnosis codes that are in place for pulmonary hypertension are really based on a very simple classification system that was developed in 1973 at the first World Symposium on Pulmonary Hypertension. And this was a group of experts that were pulled together really by the World Health Organization at the time in response to an epidemic of pulmonary arterial hypertension due to a drug called Aminorex, which was a weight loss stimulant drug that had been introduced in the late 1960s. And by the 1970s, it had been identified as a cause of pulmonary hypertension, as a potential cause of pulmonary hypertension. It was removed from the market. And at the time that these experts were convened in 1973, there was very limited information on the natural history of this disease and very little data on the epidemiology of the condition. And so at the time, based on this limited information, the experts classified pulmonary hypertension into two categories. One was primary pulmonary hypertension, and the other was secondary pulmonary hypertension. Primary being what we now know as idiopathic pulmonary arterial hypertension and hereditary pulmonary arterial hypertension, and everything else was included as secondary pulmonary hypertension. And that was the classification system that we used for the next 25 years until 1998, when a group of international experts was convened again for the second World Symposium on Pulmonary Hypertension. And in the intervening time, there had been a number of new studies, including a very large NIH-run patient registry study that really provided a lot more information about the natural history of the disease and the different categories that patients fell into. And at this 1998 meeting, the experts created a much more comprehensive set of classification for pulmonary hypertension, which is what you see here, these 5 categories. And this new classification system has really stood the test of time. With very minor modifications, these 5 groups have been reiterated by the 3rd, 4th, and 5th World Symposia on Pulmonary Hypertension in 2003, 2008, and most recently in 2013. And this classification system has also been adopted by numerous guidelines committees, including the American College of Chest Physicians, the American College of Cardiology, and the American Heart Association, as well as the U.S. Food and Drug Administration for the labeling of new pulmonary hypertension drugs. However, the draft ICD-10 CM codes for PH still reflect that earliest 1973 classification system for the disease. And so Bayer's request is a revision to the codes to align with the 5 major categories of pH that are now commonly accepted and commonly used in the clinic. And these are pulmonary arterial hypertension, or PAH, pulmonary hypertension due to left heart disease, pulmonary hypertension due to chronic lung disease and or hypoxia, chronic thromboembolic pulmonary hypertension, and pulmonary hypertension with unclear multifactorial mechanisms. And we believe that by updating these codes, we can improve consistency between the coding structure and the very well-established clinical classification of the disease, as well as improve patient outcomes, improve the ability to provide appropriate medications to patients, as well as perform more precise healthcare services research. So I believe most of you are very familiar with the entity that we call systemic arterial hypertension, which is a very common disease, affects 1 in 3 American adults. But there's another form of hypertension that affects the pulmonary circulation, and we call that pulmonary hypertension. And this is a relatively rare and debilitating disease in which we see high blood pressure in the blood vessels of the lung. And over time, that creates strain on the right side of the heart, because the right side of the heart now has to pump against a high pressure system, and that leads to right heart failure and eventually death. And the way that that manifests in patients is with symptoms of exertional shortness of breath, other nonspecific chest tightness, chest pain, some nonspecific signs of heart failure like syncope and edema, and it can be an extremely debilitating set of symptoms. And there are many ways that pulmonary hypertension can manifest because of the complexity of the pulmonary circulation, the fact that the lungs are the only organ in the body that receive 100% of our cardiac output. And so the different forms of pulmonary hypertension have been categorized into these 5 groups based on these groups having a very common pathophysiologic mechanism, a common clinical presentation, and a common therapeutic approach. And so the first group, group 1, is what we call pulmonary arterial hypertension. And the conditions on this list share in common a very characteristic vasculopathy of the pulmonary arteries. So the pulmonary arteries are the main area that are affected in this condition. And there are a number of conditions on this list. The first 2 are idiopathic pulmonary arterial hypertension and heritable pulmonary arterial hypertension. And these 2 are what we used to call primary pulmonary hypertension. Everything else in this group 1 list, as well as all of group 2 through 5, are what we used to call secondary pulmonary hypertension. So you can see the deficit that comes up already. There are a number of other conditions that are associated with pulmonary arterial hypertension, including certain drug and toxin exposures, connective tissue diseases like scleroderma, lupus, rheumatoid arthritis, HIV infection, portal hypertension that's caused by chronic liver disease, chronic congenital heart disease that has been repaired, schistosomiasis, which is extremely rare in the United States but affects about 200 million people worldwide. And the last 3 entities on this list are actually distinct from pulmonary arterial hypertension, but because of their similarities, they are grouped together in this group 1 as subcategories. Group 2, pulmonary hypertension, does not affect the pulmonary arteries at all. It actually is caused by left-sided heart disease, where high filling pressures in the heart are transmitted backwards into the pulmonary circulation, and that's caused by left-sided heart disease. Group 3 is caused by chronic lung disease with or without hypoxia or low oxygen. Group 4 PH is an entity that we call chronic thromboembolic pulmonary hypertension, and this is actually a disease that we knew very little about a few years ago, and we've had a lot more research done since the 2000s in this area, which we'll talk about. And then finally, group 5 is a set of conditions that cause PH due to an unclear multifactorial mechanisms, and this is the category that we currently use for everything else, all of the other causes of pulmonary hypertension. So briefly, group 1, pulmonary arterial hypertension, is a relatively rare disease. It has an estimated prevalence of about 15 to 50 cases per million persons. It's defined by a high pulmonary pressure, which is measured with the mean pulmonary arterial pressure during a right heart catheterization. And so you see the measurement here that we used. And you also have to have a low pulmonary artery wedge pressure, or PAWP. We also measure that during a right heart catheterization. And that tells us that the left-sided heart filling pressures are low. So that's what tells us that this is pulmonary arterial hypertension. And these patients also have to have groups 2, 3, 4, and 5 causes excluded. And when there's no identifiable cause of the patient's pulmonary arterial hypertension, we call that idiopathic pulmonary arterial hypertension. When that patient has a very strong family history of the disease, we call it heritable pulmonary arterial hypertension. There are some genes that we've identified as being associated with the heritable form, and the risk factors additionally are the conditions that I mentioned earlier on the last slide. It's important to note this form of pulmonary hypertension does respond to therapy. We have approved drugs for this disease. None of them are curative, and they're all targeted at improving symptoms and slowing down the progression of the disease. But all of them are specific pulmonary vasodilators that work to unload the pressure against which the right side of the heart has to pump. So this is one of only 2 groups that we have therapies for. Group 2, left-sided, left heart-related pulmonary hypertension is really characterized by high filling pressures on the left side of the heart with a pulmonary capillary wedge pressure of over 15, and this is really the most common form of pulmonary hypertension. It affects 80% of all the pulmonary hypertension patients because left-sided heart disease is very common. And so in this disease, again, high filling pressures on the left heart are transmitted back into the pulmonary circulation, and this causes pulmonary hypertension. This usually results from systolic or diastolic dysfunction of the left ventricle, but it can also be caused by valvular disease on the left side of the heart. And we estimate that about 16% of the 6 million heart failure patients in the US have pulmonary hypertension. And when a patient has this on top of their left heart disease, they do have worse exertional symptoms, and they have a worse outcomes and worse prognosis that we can measure. Now, there are no therapies that improve the hypertension, the pulmonary hypertension that we see in these patients. All of the treatment is directed at optimizing the patient's heart failure regimen, but no drug has been shown to improve the pulmonary hypertension component of this disease. Group 3 PH is that due to chronic lung disease and or hypoxia. So here, the most common causes in the US are chronic obstructive pulmonary disease, or COPD, and other interstitial lung diseases that are relatively common. And those conditions cause chronic inflammation and fibrotic changes in the lung over many years, as well as a physiologic response called hypoxic vasoconstriction. And those 3 accumulate to cause pulmonary hypertension, so damage to the blood vessels in the lung, which causes pulmonary hypertension. And the prevalence of this is relatively unclear, but we do know that about 90% of patients with severe COPD do have at least mild to moderate pulmonary hypertension, and about 50% of the patients with advanced interstitial lung diseases have pulmonary hypertension. And having this on top of your lung disease does portend a worse prognosis. The treatments are targeted at the low oxygen level, so we use supplemental oxygen therapy. There's no drug that's been shown to be effective for treating the pulmonary hypertension in these patients. Group 4 pulmonary hypertension is an entity that we call chronic thromboembolic pulmonary hypertension, and this is caused by chronic unresolved pulmonary embolism, which results in obstruction of the pulmonary arteries by clot that doesn't break down after a PE. And in these patients who've had a PE, we estimate that as many as 4% of survivors of the PE will go on to develop chronic thromboembolic pulmonary hypertension within 2 years of their index PE. And that also carries a poor prognosis with a median survival of about 7 years without therapy. It's important to note, though, this is the only form of pulmonary hypertension that is potentially curable. And the cure is a surgical procedure where you physically remove the clot from the pulmonary arteries. It's a very invasive procedure. It's open heart surgery. Only about 60% of the patients are surgical candidates. The other 40% have distal clot that can't be reached in a surgical procedure. So for these patients, there is an approved therapy, an approved drug that has been FDA approved. And for the patients who have recurrent pulmonary hypertension after surgery, this drug is also effective for them as well. And finally, group 5 pulmonary hypertension is caused by conditions that result in PH due to an unclear multifactorial mechanism. This is relatively rare, but every pulmonary hypertension clinic has a few of these patients. There is a long list of conditions that fall into this category. Things like sarcoidosis, a very common systemic disorder, can actually cause pulmonary hypertension through a number of mechanisms. Other conditions that can cause pulmonary hypertension through disease of the lungs and disease of the arteries are lumped into this category of group 5, where there may be many different reasons that they develop pulmonary hypertension. And this is another group where there is no effective therapy that we've identified. So some of the coding issues that become clear as we walk through these different types are the main one being that the current ICD-10 CM codes don't clearly differentiate between the types and the underlying causes of pulmonary hypertension. And throughout the pulmonary hypertension sections of the ICD-10 coding, the outdated, obsolete terminology of primary and secondary pulmonary hypertension are what is being used. And this does not align with the classification system that we commonly are using over the past 17 years. Within group 1, the I-27.0 code for primary pulmonary hypertension only refers to idiopathic pulmonary arterial hypertension and heritable pulmonary arterial hypertension, which make up only a subset of group 1. Everything else would currently fall under I-27.2, which is the code for secondary pulmonary hypertension. So that code does not distinguish between these groups of PH. And we also see that the I-26.09, 0.99, and I-27.82, although they mention cor pulmonale, which is a term for right heart failure, they don't address the pulmonary hypertension component. So they don't clearly define pulmonary arterial hypertension. For groups 2, 3, and 5, there are no codes that capture these conditions in ICD-10 CM, and so that presents a real challenge in terms of accurately reporting these conditions. For group 4 pulmonary hypertension or chronic thromboembolic pulmonary hypertension, this has really been relegated to I-27.82, which is the code for chronic pulmonary embolism. But patients who have chronic PE do not necessarily have pulmonary hypertension, which requires surgical evaluation. And so that code doesn't sufficiently characterize this condition either, nor do the I-26 codes, which refer to acute pulmonary embolism with heart failure, but don't have any mention or actually exclude chronic pulmonary embolism. And so these really, this sets up a situation where a very complex combination of codes is required to characterize group 4 pulmonary hypertension. And so based on everything that we just talked about, Bayer believes that and supports a proposed revision to the currently used codes. And I believe Dr. Bergling is going to walk through the potential revision. And so with that, I'd like to thank the committee, and I am happy to address any questions that come up.
All right. Any clinical questions at this point? Questions, comments, or thoughts? No? Okay. Thank you, Dr. Platt. And if we could we get the other presentation up on slide, let me see, slide 56, I believe it is. It'll be a little later in the presentation, so I wouldn't want to have to try to skip through 56 slides to get to it if we can avoid that. So I believe we've got that up, and here it is. So I will walk through some things, and I appreciate Dr. Platt going through all the clinical issues here, and I will say we'd gone through at least a few kind of last-minute revisions and things here. There are a few potential ways this could be handled in ICD-10 CM. As Dr. Platt had noted, the codes that we had from ICD-10, from World Health Organization, of course, knowing when ICD-10 was created in the early 1990s, it did not reflect what was decided in 1998, and we had not had other requests to change this earlier. And while pulmonary hypertension is relatively rare compared to some things, for that reason we hadn't had that come to our attention directly. Of course, it is very much common enough to make it worthwhile to add more codes for it, and 16% of 6 million heart failure cases was nearly 1 million cases of pulmonary hypertension just related to the left heart disease. So in any case, it's not an uncommon thing compared to many other things for which we have specific codes also. Looking next at the proposed code changes, let me say my initial thought on this had been, as Dr. Platt noted, we had primary pulmonary hypertension and secondary pulmonary hypertension, and the group 1, some of the things were at primary pulmonary hypertension. Group 1 includes primary pulmonary hypertension, but also includes some other things that were kind of associated, which are related to other problems. And so we'd have a few ways of handling that. At first I was looking at trying to split group 1 into 2 and have part of it there with primary pulmonary hypertension and part of it over with the other. But on further discussion, it looks like the most convenient way of handling this would be just to move the other associated things to combine them at I-27.0. So first, broadly in ICD-10 and ICD-10-CM, right now we have I-27, other pulmonary heart diseases, and we've got an I-27.0 for primary pulmonary hypertension, as well as an I-27.2 for secondary pulmonary hypertension or other secondary pulmonary hypertension. And we want to broaden what's included at these. We've had a number of things that hadn't been specifically identified, and we want to expand and create specific codes for the other groups, essentially, for each of them. So we would essentially want to modify I-27.0 so that it will be group 1 pulmonary hypertension as best we can. We would change the title to be primary pulmonary hypertension and other pulmonary arterial hypertension. And we'd add inclusion terms here for group 1 pulmonary hypertension. We would also add pulmonary hypertension with non-essential modifiers for drug-induced, heritable, idiopathic, and toxin-induced. And we would add a term, pulmonary arterial hypertension associated with other conditions. At one point I was looking at spelling out a number of those conditions, but it looked most appropriate, like the better part of valor, so to speak, to put these in our code also note and then allow people to figure those out in that way. I did, in this version at least, include pulmonary arterial hypertension due to mutation in bone morphogenetic protein receptor type 2, the BMPR2 gene. On that one, I will say Dr. Platt had actually suggested relatively late, as we were trying to review this relatively late, I'm afraid, that we just eliminate that one, because while that is the most common heritable type of pulmonary arterial hypertension, it is by no means the only one. And if we were going to try to add all the genes that could be involved, there's at least 6 of them, and as Dr. Platt said, we're likely to be discovering another every year or so here for a while, as genetics of many of these sorts of diseases becomes better understood. So it may be appropriate just to leave that out, even though it is the most common genetic issue that leads to pulmonary arterial hypertension. we're not planning to add each and every gene that might be involved for either this or any other condition in ICD. It just wouldn't be feasible as we continue discovering more genes every day. There is also pulmonary arterial hypertension with pulmonary veno-occlusive disease, PVOD, or with pulmonary capillary hemangiomatosis, PCH. Both of these are a little bit different. They're sometimes called a group 1 prime, but they are appropriately grouped with the other group 1 cases. Now, let me briefly skip forward and read this excludes 1 note. We have an excludes 1 note for persistent pulmonary hypertension of the newborn to P29.30. The proposal is also to add that. As you may recall, this is another part of group 1. It's sort of a group 1 double prime, if you like, but we would be continuing to code it elsewhere, but proposing a specific code for it also. So just to cover all of our bases as to what the different types of group 1 pulmonary hypertension are, that basically covers them. And the intent is to have most of them here at I-27.0, other than those cases involving the newborn, which would be over in the newborn chapter. And they already are sent there at this point. We would give them a more specific code also as part of this proposal. And now, finally, in addition, we would have a code also note, code also associated conditions if applicable, or adverse effects of drugs or toxins. And some of these would be adverse effect of appetite depressants, T50.5x5. You might be interested to know that the World Health Organization first got involved in this, and as I understand, was a driving force in getting that first World Symposium based on an appetite suppressant that was causing cases of pulmonary hypertension back in the 1973 time frame. So that was a little while ago. I don't know how many people are still involved with dealing with this that were involved at that point in time. None I know of, but you know, that's one of those things. It was a few years ago. I won't tell you how old I was in 1973, but not old enough to be working on this anyway. I'll say that much. Going on, with congenital heart disease, that is another thing which can also affect things. Basically, we could code also any kind of congenital heart disease that was involved. Human immunodeficiency virus, HIV disease, B20, polymyositis, portal hypertension, rheumatoid arthritis, schistosomiasis, Sjogren's syndrome, systemic sclerosis. And this is a such as list. This is not an exhaustive list, let me say. So there are other things that could also be involved, and we're not going to list all of them, but this is a representative list, I believe. If anyone has ideas on other ones that might be good to add, we'd be glad to hear it, of course. So moving on now. We do have some other excludes 1 notes that we would revise slightly to essentially note the new codes as they are proposed here. I-27.2, other secondary pulmonary hypertension. We'd be proposing new codes here, I-27.20 for pulmonary hypertension not otherwise specified. So we would have an NOS code for just the term pulmonary hypertension if someone doesn't say anything else. We're hoping they'll give us more specific information so that we can use a more specific code, of course. I-27.21 would be proposed to be the pulmonary hypertension due to left heart disease. This was the most common type. It's the group 2. It would include cases due to left heart diastolic dysfunction, systolic dysfunction, or valvular disease. And we would have a code also for the associated left heart disease if known. These would include the diastolic heart failure, systolic heart failure at the end, and also valve disorders like non-rheumatic aortic valve disorders, non-rheumatic mitral valve disorders, or rheumatic mitral and aortic valve disorders also. And we'd have code also notes for each of those. Going on, we would have a new code I-27.22. This would be for group 3 pulmonary hypertension or pulmonary hypertension due to lung diseases and hypoxia is the title. This would include cases due to COPD, interstitial lung disease, sleep-related breathing disorders, and alveolar hypotension. We would have a code also note for this code also the associated lung disease if known, such as chronic bronchitis, COPD, emphysema, interstitial lung disease. We'd also have things for morbid or severe obesity with alveolar hypotension and sleep apnea. And again, this is a such as list, not an exhaustive list. We would also create an I-27.23 for pulmonary hypertension due to chronic thromboembolic pulmonary hypertension. This would be the group 4 pulmonary hypertension. And we would have a note to code also the associated pulmonary embolism, if applicable, I-26. So these are some of our more common ones. We would also propose an I-27.24, pulmonary hypertension due to other unclear multifactorial mechanisms. This is the group 5 pulmonary hypertension. And as Dr. Platt said, they've somewhat used this as an other. So one question we might have in our deciding on the coding would be, and I didn't discuss this with Dr. Platt, but one other option would be to, we have an other secondary pulmonary hypertension code that we also are proposing as an I-27.29. And one question would be, should we just combine these and maybe make this one be the .29? And I'll see what Dr. Platt thinks about that too. If we were to do that, we'd probably title it something like pulmonary hypertension due to other unclear multifactorial mechanisms and other secondary pulmonary hypertension or something to that effect. And we'd probably put it at the .29 to make clear it wasn't other. But essentially, as I understand, they are grouping other things here if they didn't have them placed somewhere else. This would include pulmonary hypertension due to hematologic disorders, due to metabolic disorders, and due to other systemic disorders. And we would have a code also other associated disorders if known with it. And the such as list, again, would be including things such as chronic myeloid leukemia, chronic myeloproliferative disease, essential thrombocythemia, Gaucher disease, glycogen storage disease, history of splenectomy, myelodysplastic syndromes, polycythemia vera, pulmonary Langerhans cell histiocytosis, sarcoidosis, and thyroid disorders. Alphabetized list, not in the particular order of the different types or anything like that. And certainly we'll be happy to take input on anything else that should be added to that list or whether that list should be changed in any way also. Again, we would also, again, like to take input on whether it would be best to keep this as a separate .24 or just combine it with the .29 and the secondary pulmonary hypertension not elsewhere classified. If we do create a separate code for secondary pulmonary hypertension not elsewhere classified, odds are it would only be used for the term secondary pulmonary hypertension, and I don't think we'd be sending anything else there. So, as I understand, it's anticipated that term's not going to be used very much, so it wouldn't include much otherwise. So for simplicity, it could be good to combine these two codes, and while we did not show that in this original proposal, I'd be happy to take input on whether that would be a good idea. And finally, at P29, cardiovascular disorders originating in the perinatal period, we have P29.3, persistent fetal circulation. We would propose to delete certain terms directly under that and create new codes, a new code P29.30 for pulmonary hypertension of newborn, including persistent pulmonary hypertension of newborn, and also a new code P29.38 for other persistent fetal circulation, which would include delayed closure of ductus arteriosus. So that covers all of the proposed coding changes. Dr. Platt, you had talked a little about potentially wanting to see if we could make other changes in this. Would you like to say anything else about the way the codes look in this proposal, or ways you think they maybe should change based on some of our last minute discussion?
So I would say that the overall structure looks very much in line with the request and with the currently used classification. I think there's some minor subtleties. I think you mentioned the main one, the I-27.29 .24 and .29 that look like there could be some confusion if they're kept separate, and so there may be a benefit to combining those. I completely agree. And then with the small modifications that you discussed around the actual genes that cause, that may cause heritable pulmonary hypertension, I think we discussed that as well. So I think the overall structure looks like it lines up very well.
Okay. Okay. Okay, thank you, Dr. Platt. Any other comments from the audience?
Nellie Leon, Chisane American Hospital Association. As someone who has had to defend for many years why there's a need for so many codes, and especially physicians, having done some training of physicians on ICD-10-CM, and they complain about having too many codes. I wondered, and I wanted to sort of confirm, did you say that you have never had a request from physician societies or specialties on having this level of detail on a breakdown or a classification of a disease that has been in place for 17 years? Did I hear you right?
Before this, we had not had a specific request to
Right.
expand ICD-10-CM to give us more detail on pulmonary hypertension.
Nor ICD-9-CM.
And I don't think we had one for ICD-9-CM either. No.
I would say,
But
again,
not until now, anyway.
okay, having had to feel attacks and literally physical, or well, not physical, oral attacks from
Oh, dear.
physicians complaining about too many codes and why and all this other stuff, I would recommend that before you go forward with this proposal, that you get input from the relevant physician societies, because I really don't want to be having to defend codes where they say they don't document that way, or they don't think of a condition in a certain way, because also the existing structure within ICD-10-CM for the secondary pulmonary hypertension has a note that says code also underlying conditions. So you would be able to tell, number one, that it's a secondary pulmonary hypertension, and then you would have the secondary condition just like you have here. It just wouldn't be neatly classified. Is it a lung condition, or is it a heart condition, or chronic thromboembolic pulmonary hypertension? Those kinds of breakdowns would not be specifically tied to the underlying condition, but you would have the underlying condition coded separately.
So you're observing that if we just basically coded the other conditions, then we should be able to tell what group it is from the other codes.
Yeah,
There's something to that, I suppose, but
yeah, I'm afraid practicing physicians might say that, and having heard them complain about different things like that, I mean, I'm just wondering.
Some might, I suppose. Now, I will say again, this pulmonary hypertension, while it's relatively rare compared to systemic hypertension, we were just saying earlier, as I said earlier, there's close to 1 million cases of just the group 2, and that's a huge number to say, well, we don't want to give you a specific code. We'll certainly take this into consideration, but these, I would say, are much more common than many things which we have given specific codes to.
Oh, and they complain about those as well. That's why I'm trying to
I think these would provide a significant clinical utility, so speaking in favor of it. I'll let Dr. Platt speak further in favor of it, presuming I believe he would like to speak in favor of it too, but, and I see Sue's coming up too. I'll let you go since you're right at the mic, Sue. Tell us who you are.
I'm Sue Bowman from the American Health Information Management Association, and I agree with what Nellie said, and there may be some clinical utility to this structure, but I definitely would recommend, because it is so extensive, that we need broader input from the specialty groups that would be involved in this condition, because it is somewhat curious that if it's so outdated, nobody in the past has thought to suggest that this kind of breakout would be appropriate. And I'd be interested, as Nellie also said, in some of the terminology, because I wondered, are physicians really documenting group 5 pulmonary hypertension, for example? And certainly you wouldn't want or expect that the coder would be analyzing the type of pulmonary hypertension and figuring out which group it falls into so that they could code it. We would want to be careful about suggesting that. And I also have one more specific question or comment. Under the excludes one note, which I know is already there, but now I think it adds some confusion, the one that appears underneath, I guess, I-27.0 that says secondary pulmonary hypertension and sends you to I-27.29, which is now under this proposal, secondary pulmonary hypertension not elsewhere classified, and I-27.20 is pulmonary hypertension NOS, which is under a secondary pulmonary hypertension category. So I guess I'm wondering, where does unspecified secondary pulmonary hypertension go? The exclude note implies that it goes to I-27.29.
Yes,
but you
that's where
could
they go.
interpret it that I-27.20, which is in secondary hypertension and is an NOS code, why isn't that unspecified secondary hypertension?
And another option here at this excludes note, which is an existing note, I'll say, would be to send it just to secondary pulmonary hypertension I-27.2 dash, and we do use that approach, so I might be inclined to change that to a 2 dash instead of a 2.9. I'd be happy to take ideas on that too.
Well, and I also think that you need to maybe look at the I-27.20 then, because that could be interpreted, because it is in the secondary hypertension, pulmonary hypertension category, and it has NOS in the code, that someone might think that's unspecified secondary pulmonary hypertension. So if you really intended that the unspecified secondary pulmonary hypertension should go to the 2.9, it should be clearly stated that way. And 2.9, if you're going to keep that and not combine it with the 2.4, should say other and unspecified secondary pulmonary hypertension.
Okay, thank you. All right, Dr. Platt, let me give you a chance to respond to any of these things also.
Sure. I would like to comment on the question of why or how much attention has been given to this, given that the current classification, the current coding diverges very in a very pronounced way from the accepted classification. Just because a request hasn't come in for a revision does not mean that this is widely recognized as a deficiency by the pulmonary hypertension community. In fact, there's a very nice paper in CHEST from 2011 by Jeffrey Link and some of the pulmonary hypertension experts at University of Texas Southwestern, where they looked at the deaths that have been coded through the NCHS US death database. And what they found was in 2003, when a new code was added for secondary pulmonary hypertension, the number of deaths due to primary pulmonary hypertension plummeted, even though the overall number of deaths due to pulmonary hypertension encompassed by those codes stayed the same and continued to increase, which means that patients who had been formerly coded as primary pulmonary hypertension did not have that disease. And when the new code for secondary became available, many physicians began coding those patients as accurately as they could with the available codes. So I think that very clearly shows that the current coding system is deficient when it comes to the pulmonary hypertension treating community. I think for experts in this field, the codes that we're talking about are very intuitive. So these classifications are very intuitive for somebody who treats pulmonary hypertension. It is a complicated disease. It does require a number of diagnostic studies, including ventilation perfusion scans, echocardiography, in some cases pulmonary angiography, CAT scanning, and right heart catheterization. So there are many steps involved in delineating which classification a patient falls into. But for the physician who understands those tests and regularly performs these diagnostic workups, it's very intuitive for them. So I realize that there's a need to maintain simplicity and not to add many extra codes. But this is a rare disease. It does have several manifestations, and I think this would not necessarily be overly burdensome for the physicians who are treating the disease.
Okay. Thank you, Dr. Platt. And yes, I will comment as an aside that I think many doctors don't pay as much attention to ICD coding, and I suspect that might have had something to do with this not coming to our attention either. There's a relatively smaller number that do pay closer attention. We appreciate that. But it's certainly something that I think that in part probably the attention given to ICD coding with the implementation of ICD-10 CM may have been a driving factor in that's not something I heard about, but I suspect as people were looking at this closer, they were realizing, well, it would be nice if we had better ways of coding this, and then came to us with this proposal. So I think this does look like it would be an improvement. It's something we can certainly contemplate. We can certainly ask for input from groups such as American College of Cardiology and from pulmonologists and others. And Dr. Platt, certainly we'd welcome any other ideas on other medical groups who do care for these patients who might be able to provide input. So we will be looking for other input, and we'll appreciate input from everyone here. Thank you for those comments. If there's no other comments, then we'll be moving on to our next topic here shortly. And thank you, Dr. Platt, for coming. And thank you to all of you for your comments and the discussion that we've had. And I will turn it over to Donna Pickett. I believe that we'll have Dr. Utter talking again here shortly, and I'll turn it over to Donna.
Okay, Shannon? Shannon McConnell-Lamptey will lead us in the discussion of the next two proposals.
Good morning. We are now on page 49. The topic is intestinal obstruction. And this morning the speaker is Dr. Garth Utter. And he will be speaking on behalf of the American Association for the Surgery of Trauma.
Thank you, Shannon. Well, for those of you who may not have been here yesterday, or in case I wasn't very memorable when I presented yesterday, I'll just reintroduce myself briefly. I'm Garth Utter. I'm a trauma surgeon and emergency general surgeon. I work at the University of California, Davis. I'm here today representing the Patient Assessment and Outcome Committee of the American Association for the Surgery of Trauma, which, despite its name, is focused on not only the care of injured patients, but also it's the main national surgical organization dedicated to the care of emergency general surgery patients as well. So intestinal obstruction is definitely in the purview of this organization, and it's a topic that I wanted to talk about briefly today. Well, as many of you must be aware, intestinal obstruction is a process in which the intestines are physically blocked, typically by impingement on the outside of the intestine, but occasionally by actual impaction of something within the intestine. These problems are predominantly related to scar tissue adhesions, as it were, from previous operations. At least in this country, that's the primary or predominant etiology of intestinal obstruction. This tends to cause somewhere in the ballpark of 80 to 85% of all cases of intestinal obstruction, at least when we're talking about the small intestine in particular. The remainder of the cases are comprised of situations in which hernias lead to the obstruction. Occasionally cancers, usually as a secondary process, can cause intestinal obstruction, usually from such cancers as colon and ovarian cancer. But it is possible even with other tumors. And then beyond that, it gets into usually fairly rare etiologies, such possibilities as intussusception of the small intestine, ingested foreign body that gets stuck, gallstone ileus, and a variety of other relatively rare etiologies. But predominantly, this is from scar tissues from previous operation. The main distinction that clinicians use, quite honestly, to describe intestinal obstruction, particularly small intestinal obstruction, is whether or not it's partial or complete. And this is an imperfect distinction. It's often really sort of a judgment call on the case of the clinician based on the available information. But usually they account for such factors as the patient's history, physical exam findings, and sometimes even the imaging findings, increasingly CT scan findings, as well as possibly if the patient goes on to have an operation, the operative findings as well to describe it as such, partial versus complete. This distinction between partial and complete does play a role in terms of management of patients because partial obstruction implies that there's not quite as much urgency to the process, whereas a complete obstruction to a surgeon signals concern that there could be impending ischemia to the intestine, possible gangrene, perforation, and so a more serious problem potentially in the works. As I alluded to with partial obstruction, these may not require an operation. Sometimes they do, but it's quite possible that they don't require an operation. They might just resolve with a simple nothing by mouth management or by insertion of a nasogastric tube to decompress the stomach and small intestine. Complete obstruction, on the other hand, at least historically, carried kind of warnings to surgeons that you shouldn't let this last very long without just proceeding to an operation because of the risks of some of the intestine developing gangrene or perforation. And so these are more likely to result in operation. Modern management still, although there's concern about the patient progressing to complications of this process, it's more acceptable, I believe, nowadays to carefully monitor the clinical status and attempt non-operative management in a significant proportion of cases in which the patient seems to be tolerating it. And management there would involve typically insertion of a nasogastric tube and close monitoring in case an operation is necessary. I should have forewarned you, I do have a couple of pictures in this presentation and the next that show the intestines, so I apologize if any in the audience are a bit squeamish. But basically, I included these pictures to give you a sense of what we encounter at operation as surgeons. This is a fairly clear case of, although you can't see the site of blockage, that's often what happens when we operate. It takes a while for the operation to progress for us to reveal the actual impingement, but this is very classic appearance of the intestine when there's a complete obstruction. And if we don't do anything in this case, usually the focal point at which the blockage is occurring, if it's from external impingement, that focal spot is at risk for developing necrosis and perforation. If it's a really severe case and increases the intraluminal pressure to a significant degree for a prolonged period of time, that can result in infarction of a whole segment of intestine. In comparison, we don't always operate on a partial small bowel obstruction, but if we did, we might see something like this, just some scar tissue, as you might be able to recognize, between loops of intestine. This scar tissue is pretty much omnipresent after we've done an operation, and so it's not an unusual occurrence. And probably what happens in these cases of partial obstruction is that there's sort of a partial blockage or a temporary blockage of a segment of the intestine, and the intestine is analogous to a garden hose. If it just happens to rotate in a different way, it can unkink if the patient is lucky, particularly with decompressing some of the contents with a nasogastric tube. Well, there are a variety of codes that capture the concept of intestinal obstruction, and these include specific codes for intussusception, volvulus, or a twisting of a segment on itself, a twisting of a segment of the intestine on itself. Gallstone ileus, a rare situation in which a large gallstone can actually pass into the small intestine and cause an obstruction of typically the terminal ileum. Other impaction of intestine, and then intestinal adhesions, bands with obstruction. This is one of the probably most commonly used codes in this series. There are also codes for other and unspecified intestinal obstruction, and furthermore, a code in a separate part of the classification for post-procedural intestinal obstruction. If we wanted to capture other concepts related to the obstruction process, such as, in essence, complications of it when there's an infarction of a segment of the intestine or a perforation, those are captured with other codes. So what we propose as potential changes to try to capture some of the severity of intestinal obstruction better, rather than just these overarching codes that refer mainly to the etiology, is to subdivide the codes that most commonly apply to obstruction, particularly of the small intestine, with codes for partial obstruction, complete obstruction, or unspecified as to partial versus complete. And so the general pattern that we are proposing, for example, with K56.5, intestinal adhesions with obstruction, is to add an additional character to capture this distinction between partial, complete, and unspecified as to partial or complete. We would also propose a similar specification with an additional character for these three codes, or what we propose become new subcategories: K55.60, unspecified intestinal obstruction; K56.69, other intestinal obstruction; and K91.3, post-procedural intestinal obstruction. I should mention parenthetically that because the large intestine behaves quite differently, it doesn't tend to have the same type of obstruction, particularly after an operation, that the small intestine does. We haven't tried to apply these same codes to etiologies that primarily affect the large intestine, namely volvulus.
Are there any clinical questions for Dr. Utter before we look at the proposed tabular modifications? Okay. So we'll now look at the coding slide 44. Slide 44. Okay. So we're proposing at category K56, paralytic ileus and intestinal obstruction without hernia, to create a new subcategory, K56.5, intestinal adhesions with obstruction. To add 3 new codes, K56.50, intestinal adhesions, unspecified as to partial versus complete obstruction. K56.51, intestinal adhesions with partial obstruction. K56.52, intestinal adhesions with complete obstruction. To create a new subcategory, K56.560, unspecified intestinal obstruction, and add the following 3 new codes: K56.600, partial intestinal obstruction, unspecified as to cause; K56.601, complete intestinal obstruction, unspecified as to cause, and K56.609, unspecified intestinal obstruction, unspecified as to partial versus complete obstruction. Similar pattern would follow for a new subcategory K56.69 with the additional codes for partial, complete, and the unspecified as to partial versus complete obstruction. At category K91, in intraoperative and post-procedural complications and disorders of digestive system not elsewhere classified, we would be proposing to add a new subcategory K91.3, post-procedural intestinal obstruction, with the following new codes. Again, for the partial, the complete, and the unspecified as to partial versus complete listing. Are there any comments or questions?
Nellie Leon, she's saying, I think we would need some further instructional notes because there are other codes in other sections, like in the range of K40 to K46, where we have all the hernias, and some of them say with obstruction, and so some of them could be intestinal obstructions, some could be large or small intestine, I think Dr. Utter was saying. So are you sort of envisioning that if it was a hernia, there was obstruction, that you then, in addition to one of the codes from K40 to K46, you would be assigning one of these new codes?
For both.
Because right now, I mean, I could see coders sort of asking us, can you code both, or do we need some instructions?
Well, I should mention I also submitted a proposal for reconsidering some of the hernia classification as well, which we're currently in further discussions in regards to. But to my knowledge, I'd have to look back at the details, but I don't recall that there are instructions for the hernia codes to use other codes to signify.
No, they don't have that. I was looking for that as well. So I guess I was wondering, what were you sort of thinking about being able to use both codes together, or are you thinking about these independent of the hernias and should not be used with the hernia codes?
Well, I guess, on the face of it, it would seem pretty reasonable to also, apply either the same classification to the hernia codes, or to conversely allow for, use of one of these codes for cases of obstruction. But I believe that the use of obstruction for hernia is even a little bit more problematic because it doesn't necessarily refer to the intestine per se.
Yeah, it doesn't say what's obstructed. You're right. We were just looking at that.
And so, which I think is actually kind of a separate problem, to be perfectly honest with you, that requires, I believe, some clarification. But so I would be open to either approach, basically either incorporating more codes into the hernia classification to account for this distinction too, or to allow use of one of these codes to, basically to have a note to the coder to also use one of these series codes when there is obstruction.
Okay. And Sue and I were also just discussing, and she can come up to the microphone and explain it a little bit better, but we were chatting that K91.3 post-procedural intestinal obstruction could potentially overlap with several other areas, including the new one for K56.5, which is intestinal obstruction, intestinal adhesions with obstruction post-procedural. So were you thinking that this K91.3 would be for other types of obstructions? I'm not sure what the difference would be between the two new subcategories.
K91.3 versus which of the other codes?
K56.5, which also says intestinal adhesions with obstruction, and then in parentheses post-procedural.
Yeah, it's in as a non-essential modifier, so we do need to look at, did I go too far? Was it five post-procedural ANS and modifier?
Yeah, these are really already the existing codes, so we haven't done anything to, recommend changing those. The K56.5 already includes the term post-procedural. I think that...
Right, but K91.3 is the new one, and that would also
No,
say...
K91.3 already exists as well. I think K91.3, my interpretation at least, is that applies to early postoperative obstruction, whereas the K56.5 just signifies that there's been an operation in the past that has led to adhesions, perhaps even years later, causing an intestinal obstruction.
Thank you. We were looking at that as you were speaking and did make note to take that back and reconsider whether the non-essential modifiers need to be revisited. Any other comments or questions? Okay, we'll move on to our next topic on page 68 in the topic packet. And Dr. Erder will be back up to present on vascular disorders of intestine.
Well, consistent with my theme, this is another topic on which actually physicians are requesting more codes on a given topic for the existing code to be broken down into components. Acute intestinal ischemia is really a disease process that can have a number of different etiologies. Broadly speaking, it refers to the condition where there is acutely decreased blood flow to the intestine, causing inadequate provision of nutrients, namely oxygen, to the intestine. There are several different approaches one could use in trying to classify acute intestinal ischemia. One is to think of it anatomically, and from that standpoint, you might break down the main vascular etiologies into an obstruction of the arterial supply to the intestine that's caused from an embolism, one that is caused from typically, just as with, for example, myocardial infarction, a rupture of an existing plaque in one of the mesenteric arteries, namely the superior mesenteric artery, that then secondarily leads to a thrombosis. But there are also conditions in which and this is a problem that I frequently encounter as a surgeon in inpatient care, is patients who develop inadequate blood flow to the intestine just because they have poor blood flow generally to their body, and the intestines are a sensitive area to develop ischemia or infarction. Not unusually, we would see this in a patient, for example, with sepsis who is on vasopressor medications and maybe has not been adequately fluid resuscitated, and they develop, in essence, a patchy necrosis of the intestines. The entity could even include actually a process involving obstruction of venous outflow leading to poor blood supply to the intestine. This I consider almost a different category, mesenteric venous thrombosis. But the concept really can be used to extend to even a greater variety of problems. So these are really, what I've covered so far are sort of diseases of the native vessels, but there could be for example, a tear, a traumatic injury to the mesentery causing disruption of some of the blood flow to the intestine and ischemia of a segment of intestine. There could be cases of, for example, a volvulus of the small intestine such that the blood supplies become compressed from twisting, in essence, causing inadequate blood flow to the intestine. I guess you could even extend this concept to situations where there's increased pressure within the lumen of the intestines that ultimately causes inadequate blood flow to the intestinal wall, even though it doesn't involve one of the main arteries or even segmental arteries to the intestine. So any number of different etiologies could be used to classify this process. But also, very importantly, I would suggest that another very important clinical concept is that the available code really doesn't give us much information about the extent of involvement of the ischemia. And so the main ways that a physician, a surgeon in particular, would think about this is the ischemia is a temporary problem or is it an irreversible one? Ischemia in the short term can be remedied by increasing the adequacy of the blood flow to the intestine, but beyond a certain point, if the intestine is deprived of oxygen-rich blood, it will develop irreversible infarction. The disease severity is also variable in terms of there can be a very short segment or even just a part of a circumference of a very short segment, or it can involve almost all of the intestine. And these are vastly different circumstances for the patient. In one situation where it's potentially reversible, the patient may not even undergo an operation. If they did undergo an operation, as a surgeon, we might decide not to remove anything. We might decide to re-examine the patient in the operating room, again, a so-called second look operation, usually in 1 or 2 days' time. Or we might find that there is clear evidence that the intestine is dead, in which case we would resect it. If enough of the intestine is dead, this can represent a fatal problem for the patient. Or at the very best, a situation where they would be dependent for the rest of their life on nutritional supplementation through their bloodstream. Just to give you a sense of what we encounter when we operate on patients, this is a very bad problem. At the upper part of the screen is a segment, or part of the colon, and just below that, which is also identified as normal bowel, is a segment of small intestine. This is what we would want the intestine to look like. In this particular case, a very large amount of the small intestine, other than that one short segment, is dead and would have to be resected for the patient to survive. Now, I'll contrast that with another situation in which there are two areas, both very small, at this point, what appears to be completely infarcted intestine, but nonetheless, it's a very short segment. And nearby, there are areas where it looks like the bowel has an ischemic appearance, but certainly not to the point where we would generally opt to remove that segment. If there were only the small bowel aside from these two patches that are clearly dead down at the mid portion at the bottom of the screen, in these cases we might elect to just monitor the patient, reoperate again in a day or 1 or 2 days' time, evaluate the intestine again to see if some of it had died, and if so, then resect it or provide definitive treatment at that point. So the extent of the problem can be really vastly different in different cases. Unfortunately, right now, there's only one code that captures the whole spectrum of this disease, including all the different etiologies, and that is the K55.0 Acute Vascular Disorders of Intestine code. Surgeons frequently describe the anatomic location of ischemia or infarction, and obviously what they did to treat it if it involved operative resection. They also tend to use terms that could be meaningful in terms of the reversibility, whether the bowel appeared dusky, but then it became more pink over time, or that it was ischemic but not infarcted, or it was definitely gangrenous. There are a variety of terms that might be used, but surgeons do generally ascribe some characteristics to ischemic bowel that would help with further classification. And I would suggest that the details of this are important not only to understand if adequate care was delivered, but also to understand patient prognosis, to, in some cases, help determine the etiology. A certain extent might be less or more consistent with particular etiologies of ischemia, and for monitoring quality of care as well. So what we propose are a few changes, and in essence, these are permutations of really three different characteristics. And these three characteristics are, one, if it's the anatomic location, if it's the small intestine versus large intestine, or not specified as to which. The second characteristic that we would recommend differentiating cases with is whether there is reversible ischemia versus irreversible infarction. And then the third case, although I realize that this is somewhat imperfect, but some attempt to capture even within the segment of the intestine if this is the anatomic extent, if this is a focal process or diffuse one or unspecified. So, as an example, what we would recommend is adding really actually two additional characters to achieve some of these permutations. So the K55.0 code could be expanded to include, in this case, an example K55.01 for acute ischemia, which is a reversible process of the small intestine, and then three subcodes which would capture, in one case, focal acute ischemia of the small intestine, and then in another case, diffuse acute ischemia of the small intestine, and then finally, acute ischemia of the small intestine unspecified in extent. We would also use the same approach to add additional codes in this classification. So I just went through some for ischemia, which is a reversible process involving the small intestine, but we would have a separate group of codes for infarction of the small intestine, acute ischemia of the large intestine, acute infarction of the large intestine, and then similarly ischemia or infarction where the part is not specified.
Thank you. Are there any clinical questions before we look at the proposed tabular modifications? Okay. We will go to coding slide 63. The proposed tabular modifications are at category K55, vascular disorders of intestine. At code K550, acute vascular disorders of intestines, we're proposing to delete the following inclusion terms: acute fulminant ischemic colitis, acute intestinal infarction, acute small intestine ischemia, also deleting necrosis of intestine, and subacute ischemic colitis. We'll be proposing to add a new subcategory, K5501, acute ischemia of small intestine. Adding a new code K55.011 for focal acute ischemia of small intestine. A new code K55.012, diffuse acute ischemia of small intestine, and K55.019, acute ischemia of small intestine, extent unspecified. We'd also be creating a new subcategory K5502, acute infarction of small intestine, with similar codes to capture the focal, diffuse, and extent unspecified. We would also be proposing to add a new subcategory K55.03, acute ischemia of large intestine, with the following inclusion terms: acute fulminant ischemic colitis and subacute ischemic colitis. Again, following with the same proposed new codes pattern to capture the focal, diffuse, and extent unspecified. Also proposing a new subcategory, K55.04, acute infarction of large intestine, with the same pattern of new codes to follow for diffuse, focal, and extent unspecified. Adding another new subcategory, K55.05, acute ischemia of intestine, part unspecified, with the following new codes to capture focal, diffuse, and the part and extent unspecified. And also adding a new subcategory, K55.06, acute infarction of intestine, part unspecified, with the following inclusion terms: necrosis of intestine, gangrene of intestine, and acute intestinal infarction. Again, with the same new code pattern to follow for focal, diffuse, and part and extent unspecified. Are there any comments or questions?
I like the inclusion terms you have at K5506, necrosis of intestine, gangrene of intestine, because that will help the coders if that's the documentation they see. So could you add those same inclusion terms to the other acute infarction codes for the small intestine and large intestine, the
Okay.
K5502 and K5504?
Okay, thank you. Any other comments or questions? Okay, hearing none, I'm going to thank Dr. Utter. And we will move on to our next topic. It is found on page 34 in the topic packet handout. The topic is external cause codes for work-related musculoskeletal disorders caused by ergonomic hazards. The coding slide is 30. And today with us to speak on behalf of the National Institute of Occupational Safety and Health is Dr. Alicia Myers to provide some clinical background.
Thank you, Shannon. Good morning. I'm an epidemiologist at the National Institute for Occupational Safety and Health in Cincinnati, Ohio. My expertise is related to ergonomics and the prevention of musculoskeletal disorders. And I'm just going to give you a little bit of background on this proposal. I don't have slides specifically that go with this. First, I just want to explain that work-related musculoskeletal disorders caused by ergonomic hazards, such as overexertion from a strenuous movement or load, prolonged or static, awkward postures, and repetitive motions, are common and costly. And according to the Bureau of Labor Statistics, they account for 1/3 of all cases involving days away from work. The National Institute for Occupational Safety and Health, or NIOSH, and several state agencies conduct occupational health and safety surveillance activities using these external cause codes to help identify MSDs. So MSDs are unique because they're due to ergonomic hazards, and the case definition for identifying them includes both the nature of the injury, which we get from the diagnosis code, and the external cause codes. So information about both nature and external cause are required for accurate and correct classification of ergonomic-related MSDs. So for example, classically, back sprain that was caused by a slip, trip, or fall would not be considered an ergonomic-related musculoskeletal disorder, but back sprains caused by heavy lifting would be classified as an ergonomic-related musculoskeletal disorder. And according to the Bureau of Labor Statistics in 2013, 28% of strains that were caused by overexertion, while 22% were caused by slips, trips, or falls. So understanding whether a strain or some other musculoskeletal injury or illness was caused by overexertion or a fall is really important from a public health perspective, because we can then identify preventable work-related injuries and target the right interventions to a particular population of workers. And While overuse or overexertion is the most common external cause for all occupational injuries and illnesses, there's also some other physical risk factors that can be prevented by using good ergonomic practices, such as repetitive movements, awkward postures, and contact stress. Some state public health departments use external cause codes from hospital discharge and emergency department visit data as sources for occupational state surveillance systems. One state in particular, the Ohio Bureau of Workers' Compensation, has been using the ICD-10 CM external causation codes for all of their workers' compensation claims beginning in 2011. I'm going to call them the BWC, the Ohio BWC Division of Safety and Health, has been able to use causation data to target safety and health prevention programs and services to Ohio employers. Ohio BWC is a unique workers' compensation carrier because they're one of 4 state workers' compensation bureaus that are the only exclusive carrier for workers' compensation in the state of Ohio. So it's a great surveillance system for occupational injuries and illnesses because either larger companies can self-insure or you're insured by the state. And NIOSH has been partnering with the Ohio BWC since 2010 on a number of research and surveillance projects related to using workers' compensation data for occupational public health purposes. And this is how this request came up. In 2013, as the BWC was preparing for their transition to ICD-10 they asked us for help in understanding how to code overexertion in ICD-10 They were unable to find a code equivalent to the codes for E927 that were used for overexertion and strenuous movements in ICD-9 So we started investigating further and discovered that the WHO ICD-10 code X50, which would have been the comparable code for overexertion, had been deactivated in ICD-10 in response to early input from stakeholders when ICD-10 was initially developed, which was many, many years ago, as we all know. So the Ohio Bureau then initiated their request to CDC to add codes in ICD-10 that can be used in a similar manner as the E927 category. And since then, NIOSH has been working diligently with NCHS and external stakeholders to propose new ICD-10 external cause codes to address this issue. We formed an ergonomic external causation coding work group to develop the new codes that included experts from across the continent, actually, on the prevention and treatment of musculoskeletal disorders. And we believe it's really important to add these codes to ICD-10 so that we can improve occupational safety and health surveillance capacity by encouraging public health practitioners to use existing data systems that use ICD-10 such as hospitals, emergency departments, outpatient surgical centers, trauma registries, and workers' compensation claims databases. As the use of electronic health records becomes more widespread, opportunities for improving occupational health and safety surveillance systems are increasing. For ICD-10 to be useful for these purposes, for occupational health, there needs to be a way to track the absolutely most common cause of workplace injuries. If the proposed codes are not added to ICD-10 then there will not be a way to identify or track most ergonomic-related musculoskeletal disorders using the current set of codes. Any questions?
Are there any clinical questions for Dr. Myers? Okay, I'll go to the podium. Oh, too far. Okay, so the proposed tabular modifications are to create a new category X50, overexertion and strenuous or repetitive movement, to add 4 new codes. The first code, X50.0, overuse from strenuous movement or load to include lifting, heavy objects, weights. a new code X50.1 for overuse from prolonged static or awkward postures to include prolonged or static standing, sitting, twisting, bending, reaching, or kneeling. New code X50.3, overuse from repetitive movement, to include kicking a carpet stretcher with knee or use of a hand as a hammer, with an excludes to note for the overuse from prolonged static or awkward postures code, and code X50.9, other and unspecified overuse or strenuous movement or postures to include contact stress or contact pressure. Are there any comments or questions? Okay, hearing none here in the room, I will turn things back over to Donna Pickett.
Okay, Nellie, Sue, I see the two of you chatting. Before we move on to the next topic, did you have questions?
Sue Bowman from AHIMA. I don't think we had a question necessarily. We were just commenting that we noticed in the write-up that part of the reason it was deactivated and not continued in ICD-10 CM was because people thought it was the use of these codes, it was too subjective, and so the data wasn't all that valuable. So Nellie and I were having a side conversation about, essentially what has changed and are they still too subjective? And my other comment was I thought and I certainly don't object to the codes at all, but I thought that the first inclusion term under X50.3, I wondered how common that was. That seems really specific, kicking a carpet stretcher with a knee. It seems more specific than we usually get in inclusion terms.
Okay.
Maybe that's a really common thing that happens, but that was our other comment. And I guess I just wondered if these overuse codes, if they're still going to have the same problem where they're too subjective for the data to really be comparable.
Well, the Ohio Bureau of Workers' Compensation has been using these codes since 2011, and the E927 code is the most commonly used code by their coders. They probably code things a little bit differently than hospitals or emergency departments do, but they don't have trouble deciding which ones are an overexertion. So it's becoming more common for non-HIPAA covered entities to be using the ICD-10 CM, so there were some stakeholders that weren't at the table for those discussions many years ago. So that's why this has come up at this time. And then as far as the carpet, no, so this is a much simplified version of the initial proposal that we submitted. So we had a lot of we had several, let me see, 1, 2, 3, 4, 5. We had 6 different repetition categories in the initial one. So it's not that the carpet kicking is the most representative one, and we can certainly add a couple or not. It really covers things like repetitive bending over or repetitive grasping, pinching. I mean, if you have any friends who've gotten injured at work, who've had more manual type labor, it's not this one particular incident that leads to that injury, but continually doing that kind of work over a period of time.
I feel like Donna sort of caught us talking in class. But the other thing that I was looking at is that as I was looking at the other X codes, the other blocks, they all seem to refer to exposures to something. So I was trying to see if that was kind of like the best place to categorize this. But if that's where WHO has it, I mean, that's fine. But probably something will need to be done either to create a new block, because as I look, there's exposure to smoke, fire and flames, exposure to natural forces, exposures to, so they're all in that grouping of exposure to something, and this didn't seem to fit that way of breaking it down. But I mean, if that's where WHO has it, that's where it should go, but we'll need some sort of guidance. Yeah.
And I mean, Shannon can talk about that also. I will say that the X50 category name, we can't change. We wanted to change that to something that was a little bit more modern and representative, but we were told that it had to be consistent with what the WHO uses. Do you want to say anything?
Oh, no, that was definitely right on target. What I would like to ask is that if we have any facility coders in the audience, if you could give us some feedback, maybe on if these are some of the terms that you have seen in the record, or just how well documented they are when it comes to the external cause codes and the mechanisms being documented. Are there any facility-based coders, consultants? Okay. Okay. If nothing else, I will turn things back over to Donna Pickett.
Okay, in your topic package, please turn to page 27. That'll be slide 23 in the PowerPoint presentation. We've received a request from Merck & Company proposing new codes related to encounters for implantable subdermal contraceptive management. And this is actually sort of an add-on to a ACOG proposal that was presented in September. Is there anybody from Merck & Company here? Good, okay, thank you. To provide some clinical background, but again, what we're doing here is merging for your review and better understanding the codes that were presented by ACOG in September and the new Merck proposal. And I'll now ask the gentleman to introduce himself.
Thank you, Donna. Good morning. My name is Dr. Charles Dubos. I work for Merck. I'm one of the medical affairs directors. My background is in women's health. I'm an OB-GYN by trade. Do we have slides for? I don't think we received it. Okay. So she's looking to see if they can find the slides, I guess. Don't see. Don, I believe we have them on a flash drive. Oh, there we go. All right, so I wanted to briefly speak with you this morning about contraception and ICD-10, our diagnostic code proposal. The agenda is that I'll give you a little bit of background about our products and contraception, what we're proposing as a company, some issues that have been recognized, what our goal is, and then a conclusion. So Merck actually has two contraceptive products. One of them is Nexplanon, and Nexplanon is a long-acting reversible contraceptive, which ACOG actually has been endorsing and has stated that LARCs should be thought of as first line based on a technical bulletin that was published in July of 2011. Nexplanon is a subdermal implant that contains 60 milligrams of etonogestrel. It is radio-opaque. It actually goes in the non-dominant arm. It is inserted with a trocar, should not be used for more than 3 years, and for a clinician to place Nexplanon, they have to be manufactured trained. Nexplanon and NuvaRing, our other contraceptive method, actually require several visits, and the ICD-10 diagnosis code descriptions are clearly defined for the subdermal implant. Next, I'm going to speak on NuvaRing, which is our other contraceptive. It is a vaginal ring that contains etonogestrel and ethinyl estradiol, so it has an estrogen and a progestin. It is placed in the vagina and it stays in for 3 weeks, and then it's removed after 3 weeks. The patient experiences a withdrawal bleed. NuvaRing should not be used in women over the age of 35 who are smokers because it actually puts them at an increased risk for a vascular event. That could be a stroke, a cardiovascular event, or it could be a DVT. The older she is and the more that she smokes, the higher risk she is for a vascular event. So what we are proposing is additions and modifications be made to ICD-10 for the subdermal implant and the vaginal ring to be able to differentiate encounters so that the needs of the patient and the provider are met as it relates to contraceptive management and other devices. We know that the crosswalk to ICD-10 is actually more general than it was for ICD-9. And even with ICD-9, there were some encounters that weren't accounted for instance, removal and insertion. So what we're proposing is that new encounter codes be made for the subdermal implant and the vaginal ring that have the same identical format as what is seen with intrauterine contraception. We are also proposing that as it relates to the CVR, or contraceptive vaginal ring, that have the same format as oral contraceptives as it relates to initiation and surveillance. And some of the issues that we have defined are we know that there are codes for ICD-9, specific encounter codes as it relates to the subdermal implant. And we know that these codes actually allow clinicians to be able to track their patients as relates to removal reminders, and it also can be utilized in clinical studies as it relates to utilization, duration of use, and outcomes. I'd mentioned in the previous slide that the crosswalk to ICD-10 is more general than it is for ICD-9, and actually as it relates to the subdermal implant, there is no differentiation relating to implantation, surveillance, or removal. And Z97.5, presence of intrauterine contraceptive device, is available for IUD patients, but there's no corresponding code for patients with the subdermal implant. As a result, ACOG has made some recommendations. ACOG stands for the American Congress of Obstetrics and Gynecology. And there have been 2 recommendations that have been made until new codes can be added. One of the recommendations is Z30.018 that actually talks about or would represent the encounter for initial prescription of other contraceptives. The other one is Z30.49, which is an encounter for surveillance of other contraceptives. More specific, ICD-10 diagnostic codes would allow providers to track more of the encounters more effectively. For example, as relates to the implantable, track the encounter, track the removal and or reinsertion dates to ensure adherence to the 3-year duration period. And regarding the vaginal ring, to track the initiation and surveillance to help ensure adherence. We also identified 3 other issues. There's an increased utilization or increased importance of LARCs. And once again, this has been endorsed by ACOG, and that LARCs are thought of as first line. We also know that under the Affordable Care Act, that preventative services such as contraception Counseling, education, and providing contraceptive methods are required to be covered by all insurance plans. The other thing is that payers can deny incorrectly coded encounters. As a result of that, patients may not be able to receive the contraceptive services in a timely manner, which could lead to an unintended pregnancy. And we all know that unintended pregnancies happen about 50% of the time. And we also know that unintended pregnancies are a significant financial burden on the United States. So really, we've got 3 goals. One is to reduce the opportunity of unintended, unplanned pregnancies as a result of improper coding. We also have the goal of ensuring that providers are able to maintain and provide effective care, also as relates to clinical research, to be able to track the utilization, duration of care, and outcome of contraceptives. And another goal is to suggest changes in areas where ICD-10 coding does not adequately mesh with what is being done clinically. And these changes would help to ensure consistent coding and or reporting. So our conclusion: implantable subdermal and vaginal ring have encounters that are not being accounted for with regards to ICD-9 and ICD-10. Other contraceptive methods actually have more specific encounter codes, and so we are requesting that we have the same level of specificity. We also know that providers rely on diagnostic codes to determine patient adherence, also for monitoring, and it's also used in clinical studies. We know that claims are being denied as a result of improper coding, which can lead to unintended pregnancies. And it is essential to have a mechanism to differentiate the different encounters for the subdermal implant and the vaginal ring in ICD-10. Thank you.
Before we go on with the coding proposals, are there any questions that anyone had for Dr. Dubose? Okay, so we'll go back to slide 23. Yeah. Okay, so again, as I was indicating earlier, our starting point in taking the Merck proposal was to join it with the proposal that was brought to us for the September 2014 meeting from ACOG. And what we've done is harmonized the 2 proposals because there were overlap. The original Merck proposal was addressing the ring as well as the subdermal, and we'd already had presentations from ACOG on that. So what you're seeing here, the Merck proposal specifically now addresses only the things that weren't included in the ACOG proposal, and those are shown in bold. But what, again, we've done here is we've brought both proposals together so that you can see the continuity of the codes and how they'll harmonize. Originally, we were just going to present the Merck proposal only, but we realized because there was a break in the code numbers that you'd probably all be very confused at what you were looking at, so we brought them together to make it look a little bit more understandable to you in reviewing the proposal. Dr. Dubose covered a great deal of background already, and then of course we had the background that was presented as part of the September proposal. So without going through all of the additions, I'd like to ask if there are any questions, comments, or concerns about the revised proposal that you're seeing before you now. And I will make one comment that we are getting clarification working with ACOG. The earlier ACOG proposal used the word device in some of its code proposals, and we're just clarifying now what is or what isn't a device. as it relates to these codes. Some confusion. We did get clarification from Merck that the subdermal is not considered a device. But again, we're looking for industry input and guidance also from FDA, as I discussed with ACOG yesterday, to make sure we have the terminology correct and that it is properly represented in the classification. So are there any questions about the code proposal or any questions you may have come up with for Dr. DuBose? Okay, well, again, we invite your comments by November 13, so if you're not able to think of anything right now, or you want to go back and check the previous proposal, we encourage you to do that and get your comments into us. Okay, we will move on to our next proposal, which will be found on page 44, and that's the hypophosphatasia, and I will shorten that to call it HPP. Do we have a representative in the audience that was going? There, okay. Please come to the podium. Oh, okay, that's good. And you do both, right? HPP and the LAM.
Yeah. So good morning. My name is Dr. Ileja from Alexion Pharmaceuticals. I'm a VP for Medical Affairs for HPP, and we have a second application for LAL-D, and my partner couldn't be here, so I may be able to speak to that as well. So we're making a request for a new ICD-10 code for HPP, and HPP is a very rare genetic disease, an inborn error of metabolism, where patients who are afflicted aren't able to make a very common enzyme called alkaline phosphatase. Alkaline phosphatase is a very commonly tested biochemical marker that is widely available, and the lack of alkaline phosphatase results in patients not being able to mineralize bones and teeth. This manifests clinically in very devastating manifestations, such as inability for newborn kids to have rib cages, and if you think about it, you need your ribs to generate inspiratory pressure, and these kids often end up dying. If you look at x-rays of the ribs, they're very thin. You would almost see no mineral at all. This disease affects patients all the way through adulthood as well. There's a varying amount of severity as the clinical manifestation changes from the perinatal, which is almost completely fatal. Kids who are diagnosed at birth are likely to die, all of them, by age 1. And those who are diagnosed a little later after birth can survive, but about half of them die by year 1. So it's a very severe and devastating disease. So what we're requesting is right now we have a very general code, which is a disorder of phosphorus metabolism. HPP is actually a lot more than that. HPP is specifically an enzyme deficiency that impacts mineralization as well as calcium and phosphorus metabolism. It's very difficult now to actually get an accurate estimate of the incidence and prevalence of a disease, partly because of lack of an interest in terms of there's been nothing that can be done for the patients up until now. We have an approved medication in Europe, and the US is under review right now. So there's a need now to start thinking of how we can specifically code for HPP. It will facilitate greatly not only diagnosis and appropriate coding, but also facilitate any health services research as we begin to look at patients after they've been diagnosed. So that's a very high-level introduction to HPP. As I mentioned, it's a genetic disease. There are over 300 mutations that have been identified that cause HPP, and every day new mutations get identified. Inheritance can be either autosomal recessive, which is the most likely way for the severe disease, or it can be autosomal dominant. And the disease is found primarily in Caucasian descent people. So it's not, every ethnicity is not equally afflicted, but the prevalence varies very widely. in some populations, especially in Canadian Mennonite population, they have prevalence as high as 1 in 2,500. In other populations, it can be as rare as 1 in 300,000. So again, ethnicity is very important in determining prevalence and severity of the disease. It's very rarely found in people of African descent, but it has been described as well in those populations as well. So Alexion Pharmaceuticals is making this request because we believe it's going to greatly impact how patients are categorized, how care is coded, and how we can actually understand these patients once they've been diagnosed and put on medical therapy. So, thank you.
Okay, if we could go to slide number 39. Okay, so for this proposal for HPP, we're proposing one new code, E83.33, with some code notes that code also, if applicable, any associated conditions, and we've listed a few such ases. Again, it's not the exhaustive list. And also, of course, we would have an other code, E8339, other disorders of phosphorus metabolism. So 2 codes. Any questions or comments, either of a clinical nature or related to the proposal? Okay. Hearing none, we'll move on to the next presentation, and that will be found on page 51, and that would be slide 47.
So, good morning again, Dr. Ileje. As I mentioned earlier, my colleague, who's the head of the medical affairs team for this particular product, was unable to attend this meeting, so I will be speaking on behalf of her. This lysosomal acid lipase deficiency is, again, a very rare inborn error of metabolism where patients who are afflicted by this disease have a defect in their LIPA gene. Now, what this does is it creates an inability for these patients to break down cholesterol esters and triglycerides, and these accumulate in all the cells diffusely throughout the body. LAL deficiency was poorly understood and initially categorized as 2 different diseases, one affecting kids and one affecting adults. The disease has since been understood to be a continuum of the same process, where the diffuse nature of the accumulation of the cholesterol esters and triglycerides led to an initial thought that there were 2 different diseases, but it's one continuous disease with a very high mortality. Now, the clinical manifestations, as you might imagine from what I've described to you, include fairly common early acceleration of atherosclerosis with cardiovascular manifestations and risk in very young kids, as well as very severe infiltration of fat into the liver, which causes cirrhosis, liver failure, liver cancer, and need for transplant in these patients. So a fairly severe disease. Alexion Pharmaceuticals, up until recently, wasn't involved in this disease area, but by way of an acquisition of a company that developed the replacement therapy for this deficiency called Synergiva, we become very obviously interested in getting this disease better characterized. When you look at incidence and prevalence, again, very poorly characterized because the disease was very poorly understood. With increasing understanding that this is one disease, we're proposing a new classification, a new code for LAL deficiency, and this proposal actually has been done in partnership with some patient advocacy groups, which Synergiva had contacted before the acquisition occurred. Also, the North American Society for Pediatric Gastroenterology and Hepatology and Nutrition is also interested in this new code being developed. So what we're requesting is a new code for LAL deficiency, which I'm sure Donna would actually explain to you. I'm happy to take any clinical questions.
Before we go into the code proposal, are there any clinical questions? Okay, so as you can see on the slide and in topic package on page 53, we're proposing a modification at E75.5, striking the inclusion terms that are currently found there, creating two new codes, E7551 for loud deficiency, and moving Wallman's disease into an inclusion term at E7551. Code also notes, and again, this is not the definitive list. These are such as based on recommendations from the submitter. We would have an excludes one note to exclude disorders of lipoprotein metabolism and other lipidemias to E78-, and then new code for other specified lipid storage disorders. Are there any questions on the proposal itself? Okay. Hearing no additional comment or questions, we'll thank the presenter. Thank you so much.
Thank you.
Okay. And again, November 13, just as a reminder. And with that, we'll move on to our next proposal, which can be found on page 17, ALS, and the accompanying slide is slide number 9. And I won't walk you through the entire background because you have it in front of you. I will note that this is coming from CDC, from the Agency for Toxic Substances and Disease Registry. The issue at hand is in ICD-10, they included at the code, well, there was no breakout in ICD-10 for motor neuron diseases beyond the 4-character code. In ICD-10-CM, we did do a breakout, G12.20 through G12.29, but in creating the code for the G12.21, it was noted by ATSDR that there were some inclusion terms that WHO had built into ICD-10 that truly did not, were not synonymous with ALS. And so what they're asking for is further refinement of the existing codes to make ALS a separate standing code and that no other inclusion terms be included there and they be placed elsewhere, with the idea that CDC has been tracking ALS through its registry, but they also rely on the ICD-9 CM codes currently, and in order to continue to use the relevant ICD-10 CM code, they need to have that code be unique to ALS, and that is what this proposal is describing for you. So if there are any questions, Dr. Powers, I was looking in your direction.
Laura Powers, American Academy of Neurology. No, and we're all for this because we love registries. We want to help, and that's makes sense to push that down to another level. But I did by email talk to 2 different neurologists who run ALS clinics, and the suggestion from the second was that well, it turns out that both progressive spinal atrophy and primary lateral sclerosis phenotypically turn into ALS. So eventually they'll wind up with the ALS code. But because PLS already has its own code, the recommendation was, since we have this opportunity and we have the room, why don't we just go ahead and give progressive spinal muscle atrophy its own code and also familial motor neuron disease its own code, and go ahead and do that while we're changing this, and then have the other just without anything under it for right now.
Okay. Dr. Powers, would you be able to provide the breakout for us?
Sure.
Okay, great, thank you. Any other comments or questions on this proposal? Okay, thank you. I think I'm looking at my staff now to make sure we've covered all the proposals before we move into the addenda portion, and Tracy Ramirez will be presenting the addenda. So we've covered everything.
Yes. Okay, we're going to be on page 71 in your topic packet, slide 67. Okay, so we're going to start off at D46. We are going to change myelodysplastic syndromes. We're going to change the, there was an incorrect on the RAEB. It was incorrect, so we are changing that to the correct, to correct it, to show that that is correct now, I'm sorry. And then under D64.8, other specified anemias, we are deleting the excludes one note for anemia and neoplastic disease and making that an excludes two note. And under D61.8, again changing the pancytopenia due to with etc., changing that from an excludes one note to an excludes two note. And moving on to E29, we are under testicular dysfunction in the excludes one note. Currently there's a code Q98.2. We are removing that. And under E66, overweight and obesity, we are adding the inclusion term of obesity hyperventilation syndrome. Under F52, we are, F52.0, hypoactive sexual desire disorder. We are moving the parens there under sexual. At G00, G00.1, pneumococcal meningitis, we're adding inclusion term of meningitis due to streptococcal pneumoniae. At H42, we are deleting the diabetes mellitus line under excludes one and putting it under excludes two. And at I20.8, other forms of angina pectoris, we are adding stable angina. At L70.5, we are deleting the des Junevillus as co-title and adding it as an inclusion term. And at L82, we are adding basal cell papilloma under the seborrheic keratosis. And we are correcting a typo in under L89, L89.521. Persistent was incorrectly spelled, so we are correcting that. Under R00, abnormalities of heartbeat, we are removing specified arrhythmias from the excludes one and adding it as an excludes two. At R01, cardiac murmurs and other cardiac sounds, we are also at R01.1, we're adding an inclusion term of systolic murmur, NOS. And under symptoms and signs involving the digestive system and abdomen, we are revising The current excludes of signs and symptoms involving the urinary system, R30 to R39. We're moving that to and excludes 2. And as well as symptoms and signs involving cognition, perception, emotional state, and behavior, R40, R46. We are also removing the excludes 1 and making it an excludes 2. And under T80.6, other serum reactions, we're correcting, we're adding the full range from B16 to B19 in the excludes 2 note for serum hepatitis. And under transport accidents, it was requested to change the note for the definitions, instead of it being definitions of transport vehicles, to change it to definitions related to transport vehicles. And under V47, car occupant injured in a collision with fixed or stationary object. It was requested to delete the code V4701 for sport utility vehicle, since sport utility is different than a car. And so in V47.1 and V11 and then V47.3, deleting V47.31 as, again, the SUV is different than a car. And at V47.5, the same thing, V47.51, taking it out of the car, and since it's not a car, it's an SUV. Under assault, we are revising the range of codes from X92 through Y08 to include Y09. And under misadventures to patients during surgical and medical care, Y62 through Y69, we are actually removing the excludes 2 note and adding it as an excludes 1 note. And under medical devices associated with adverse incidents in diagnostic and therapeutic use, we are also removing the excludes 1 note and making it an excludes 2 note. Under surgical and other medical procedures as the cause of abnormal reaction of the patient or of later complication without mention of misadventure at the time of the procedure, we are at Z01.41, we are deleting, first we are adding the use additional code to identify abnormal findings under Z01.41 and removing that from Z01.419. And under Z12.4, encounter for screening for malignant neoplasm of cervix, we are revising the excludes 1 note to make it an excludes 2 note. And at the use additional code note under Z3A, weeks of gestation, we are adding if applicable to the note under codes from category Z38 are for use only for the maternal record to indicate the weeks of gestation of the pregnancy, if applicable. And under Z79, Z79.89, we are revising the excludes 1 methadone use, NOS, to include, to remove F F11.2 and adding F11.9. Or excuse me, just removing the F11.2. And under Z 99.2, dependence on renal dialysis, we are removing the excludes one note of non-compliance with renal dialysis to an excludes two note. And that's all for the tabular modifications. Are there any questions?
For the codes you were deleting for the SUVs, did they get moved somewhere? I'm just wondering how those would be coded now that they've been deleted. I understand that SUVs are considered a truck rather than a car, but I was expecting you to show up, the code showing up somewhere else.
Yeah. I will have to double check that, Sue, and get back with you on that.
And my other question, could you go back to the slide that had to do with the excludes notes on the, I think it was the misadventures?
Okay.
This one? Where you were changing, yeah. I was just wondering, couldn't you have, it always worries me when we change an excludes 2 to an excludes 1 because people can always manage to find scenarios where you could code things together.
Right.
I guess I just wondered if you couldn't have a misadventure and then if there wouldn't be situations where you would have different occurrences in those different ranges of codes on the same patient, and now we're saying that those two ranges could never be coded together under any circumstances. Excludes ones always make me nervous unless they're clearly specific to a condition or scenario that are completely mutually exclusive and could never occur in the same patient during the same encounter, I guess is my concern.
Right. That was a request from 3M, and we will go back and double check that. Are there any other questions? Okay, and for the index, under anemia, we are deleting failure kidney. And under angina pectoris, we are correcting the stable angina from I-20.9 to I-20.8. Under complications, coronary artery, specified type, we're correcting the code from T82.897 to T82.898. Under vaccination, T88.1, myelitis, we are changing the code from we're removing the code G04.89 and adding G04.02. Under diabetes with, we are adding gastroparalysis. And under due to drug or chemical with, we are also adding gastroparalysis, E09.43. And diabetes due to underlying condition with gastroparalysis, E08.43, and as well as diabetes due to with adding gastroparalysis. And we're also adding gastroparalysis under diabetes with gastroparalysis, type 1, and adding it under, right above type 2, below gastroparalysis type 2 with gastroparalysis. And also adding the uncontrolled under E11.65. Under disorder, attention deficit without hyperactivity, we are correcting the code from F90.0 to F98.8, as well as revising under dysmorphic body F45.1 to F45.22. Under dissection, artery, we're adding pre-cerebral congenital, non-ruptured. Under ear, we're revising the code at tropical from B36.8 to NEC B36.9. And also adding ear, tropical N, aspergillosis B44.89, as well as candidiasis B37.84 and moniliasis B37.84. And we are deleting septic under enteritis as the non-essential modifier. And under fracture, pathological, due to osteoporosis, at M80.80 is incorrect, and we are adding M80.00. Under hypopituitarism, juvenile, postpartum, we are adding 099.285. At Lennox cirrhosis, we're correcting and adding K70.30. With ascites, K70.31. Alcoholic, under non-alcoholic, it's K74.69. Under meningitis, we are adding streptococcal pneumoniae under pneumococcal. And we are also adding streptococcal pneumoniae, G00.1. Under meningioencephalitis, we're revising under N, Haemophilus influenzae H. We're removing the G04.2 and adding G00.0, as well as under meningoencephalitis influenza H, influenzae, doing the same, removing the G04.2 and adding G00.0. And we were revising under methadone use, F11.20. We're removing the F11.20. And we are adding under morbid obesity with alveolar hypoventilation. We are adding obesity hypoventilation syndrome, E66.2. Under mycosis, mycotic, ear, we are revising the code from B36.8 to B36.9 and adding the following inclusion terms that were proposed in the tabular. Under necrosis, necrotic, we're revising under pituitary, removing postpartum and Sheehan, and adding them under pituitary as postpartum and Sheehan. Under newborn, we are revising the code for apnea from P28.3 to NEC P28.4. as well as adding under newborn apnea sleep, P28.3 We are adding that and then deleting the specified P at P28.4. And under non-traumatic subarachnoid hemorrhage from unspecified intracranial artery, we are revising ruptured cerebral aneurysm, I60.7. And under obesity, E66.9, adding with alveolar hyperventilation, E66.2. And under osteomyelofibrosis, we are correcting the code from D75.89 to D47.4. And under otitis, ear, externa, in, we're revising mycotic and adding NEC, as well as otitis, ear, mycotic, we are adding in, as well as the following: aspergillosis, candidiasis, and we are revising tropical at B36.8, removing that, and adding NEC, B36.9. And under peritonitis, we are revising under with or following appendicitis from K35.2 to K35.3. Under reaction, toxic, revising the code from T81.89 to T88.59. Under strabismus, cyclotropia, we are correcting the code from H50.1 to H50.41. At terrorism involving hot substances, we are correcting the code from Y38.56 to Y38.3X. Under tobacco, nicotine, tobacco abuse, we are adding abuse C tobacco use, as well as abuse history, adding history Z 87.891. Under urgency, adding urinary, revising the code from N39.41 to N39.15. And use of alcohol with intoxication, we're adding that, and we are revising use alcohol with intoxication. Methadone, we are revising that and removing F11.20. Where's the rest of it? Oh. Looks like we were the use of. Okay, it looks like we were missing one last page, but you should have it in your topic packet. And it's a revision of the table of drugs and chemicals under T38.0, under poisoning by adverse effect and underdosing of glucocorticoids, and synthetic analogies, where we are deleting hydrocortisone derivatives under T49.0x1, 0x2, 0x3, 0x4, etc., and adding them under code T38.0x1, T38.0x2, T38.0x3. Also in the external cause of injuries index, it was requested to remove and under accident due to transport motor vehicle to revise it from V86.39 to V89.2, and to delete driver V86.09, as well as hanger on V86.29, to revise the code under non-traffic from V86.99 to V89.0, and to delete the following codes under for driver as well as hanger on passenger while boarding, and revise the code under sport utility vehicle occupant to remove see also accident transport car occupant, as well as to delete collision with stationary object, driver, collision with, stationary object traffic, non-traffic, passenger collision with, stationary object, and non-traffic. And are there any questions? Okay, thank you.
Okay, this does get us through all the proposals, right? Okay. Again, just checking to make sure we haven't overlooked anything. This concludes the diagnosis portion of the ICD-10's Coordination and Maintenance Committee. Today is September 23rd. We're in countdown. We are 7 days away. So again, pat yourselves on the back. Give yourselves a round of applause for all the hard work that all of you have done to get us to where we are. We know we wished it could have been sooner, but it's coming, and we're all, I think, quite happy that we're here. So again, thank you all. Thank you for coming. And we hope to see you on March 9th and 10th for the 21st 2016 meeting. And again, please get your comments in by November 13, sooner if you're able to do that, and we look forward to receiving them. Thank you, and have a good rest of the day.